Hi, and welcome to today's Daily Chronicle. Today is Friday, November 8th, 2024. How healthcare could change under the new Trump administration. Former President Donald Trump, election's victory, and coming return to the White House will likely bring changes that scale back the nation's public health insurance programs, potentially increasing the uninsured rate while imposing new barriers to abortion and other reproductive care. The reverberations that felt far beyond Washington, D.C., and could include an erosion of the Affordable Care Act's consumer protections, the imposition of work requirements of Medicaid and funding cuts to the safety net insurance, and challenges to federal agencies that safeguard public health. Abortion restrictions may tighten nationwide with possible effort to restrict the mailing of abortion medications. And with the elevation of vaccine skeptic Robert F. Kennedy Jr. to Trump's inner circle of advisors, public health interventions with rigorous scientific backing, whether fluoridating public water supplies or inoculating children, could come under fire. Trump's victory will give a far broader platform to skeptics and critics of federal health programs and actions. Public health authorities worry that in a worst case, the U.S. could see increases in preventable illnesses, a weakening of public confidence in established science, and debunked notions, such as a link between vaccines and autism, adopted as a policy. Trump said in an NBC interview on November 3rd that he would make a decision about banning some vaccines, saying he could consult with Kennedy and calling him a very talented guy. Here's what's to know about how Trump administration might do on several major issues in healthcare. Changes to Obamacare. While Trump has said he will not try to repeal the Affordable Care Act, his administration will face an immediate decision next year on whether to back an extension on enhanced premium subsidies for Obamacare insurance plans. Without the enhanced subsidies, steep premium increases causing lower enrollment are projected. The current uninsured rate, about 8%, could rise. Policy specifics have not moved far beyond the concepts of a plan. Trump said he had during his debate with Harris, though Vice President-elect J.D. Vance later said the administration would seek to inject more competition into ACA marketplaces. Republicans claimed a Senate majority, in addition to the White House, while control of the House is not yet resolved as of Wednesday afternoon. Polls show the ACA has gained support among the public, including provisions such as pre-existing condition protections and allowing young people to stay on family health plans until they are 26. Trump supporters and others who have worked in his administration say the former president wants to improve the law in ways that will lower costs. They say he has already shown he will be forceful when it comes to lowering high healthcare prices, pointing to efforts during his presidency to pioneer price transparency and medical costs. On affordability, I'd see him building on the first term, said Brian Blase, who served as a Trump health advisor from 2017 to 2019. Relative to a Democratic administration, he said there will be much more focus on minimizing fraud and waste. Efforts to weaken the ACA could include slashing funds for enrollment outreach, enabling consumers to purchase more health plans that don't comply with ACA consumer protections, and allowing insurers to charge sicker people higher premiums. Democrats say they expect the worst. We know what their agenda is, said Leslie Dock, executive chair of Protect Our Care, a healthcare policy and advocacy organization in Washington, D.C. He worked in the Obama administration helping implement ACA. They're going to raise costs for millions of Americans and rip coverage away from millions, and meanwhile, they will give tax breaks to rich people. Theo Merkel, a director of the Private Health Reform initiative at the right-leaning Paragon Health Institute, which base leads said the enhanced ACA subsidies extended by the Inflation Reduction Act in 2022 do nothing to improve plans or lower premiums. He said they paper over the plan's low value with larger government subsidies. Drug price negotiation. Other Trump supporters say the president-elect may support preserving Medicare's authority to negotiate drug prices. Other provisions of the IRA. Trump has campaigned reducing drug prices and in 2020 advanced a test model that would have tied the prices of some drugs in Medicare to lower costs overseas, said Merkel, who worked in Trump's first White House. The drug industry successfully sued to block the program. Leadership of health agencies. Within Trump circles, some names have already been floated as possible leaders for the Department of Health and Human Services. They include former Louisiana Governor Bobby Jindal and Seema Verma, who ran the Centers for Medicare and Medicaid Services during the Trump administration. Kennedy, who suspended his independent presidential run and endorsed Trump, has told his supporters that Trump promised him control of HHS. Trump said publicly before Election Day that he would give Kennedy a big role in his administration, but he may have difficulty winning Senate confirmation for a cabinet position. Cuts or restrictions on Medicaid. While Trump has vowed to protect Medicare and said he supports funding home care benefits, he's been less specific about his intentions for Medicaid, which provides coverage to lower income and disabled people. Some health analysts expect the program will be especially vulnerable to spending cuts, which could help finance the extension of tax breaks that expire at the end of next year. Possible changes include the imposition of work requirements on boundaries in some states. The administration and Republicans in Congress could try to revamp the way Medicaid is funded. Now, the federal government pays states at variable percentages of program costs. Conservatives have long sought to cap the federal allotments to states, which critics could say could lead to draconian cuts. Medicaid will be a big target in the Trump administration, said Larry Levitt, Executive Vice President for Health Policy at KFF, a health information nonprofit that includes KFF Health News. Reproductive health. Less clear is the potential future of reproductive health rights. Trump has said decisions about abortion restrictions should be left to the states. 13 states ban abortion with fewer exceptions, while 28 others restrict the procedure based on gestational duration, according to the Guttmacher Institute, a research and policy organization focused on advanced reproductive rights. Trump said before the election that he would not sign a national abortion ban. State ballot measures to protect abortion rights were adopted in 7 states, including Missouri, which Trump won by about 18 points, according to preliminary AP reports. Abortion rights measures were rejected by voters in Florida and South Dakota. Trump could move to restrict access to abortion medication, used in more than half of abortions, either by withdrawing the FDA's authorization for drugs or by enforcing the 19th century law, the Comstock Act, that abortion opponents say bans their shipment. Trump said he generally would not use the law to ban mail delivery on the drugs. We checked up on the states that promised transparency on opioid settlement funds. To discover how millions in opioid settlement funds are being spent in Idaho, you can visit the Attorney General's website, which hosts 91 documents from state and local entities getting the money. What you'll find is a bureaucratie Nearly 3 years ago, these jurisdictions signed an agreement promising annual reports specifying the activities and amounts they have funded. But many of these reports remain difficult, if not impossible, for the average person to decipher. It's a scenario playing out in a host of states, as state and local governments begin spending billions in opioid settlement funds. One of the loudest and most frequent questions from the public has been, where are the dollars going? Victims of the crisis, advocates, and public policy experts have repeatedly called on governments to transparently report how they're using these funds, which many consider blood money. Last year, KFF Health News published an analysis by Christine Minhee, founder of an opioid settlement tracker, that found 12 states, including Idaho, had made written commitments to publicly report expenditures on 100% of their funds in a way an average person could find and understand. The other 38 states promised less. But there's a gap between those promises and the follow-through. This year, KFF Health News and Minhee revisited those 12 states: Arizona, Colorado, Delaware, Idaho, Massachusetts, Minnesota, Missouri, New Hampshire, New Jersey, Oregon, South Carolina, and Utah. From their reports, it became clear that some did not fulfill their promises, and several just squeaked by, meeting the letter of the law but falling far short of communicating to the public in a clear and meaningful manner. Take Idaho, for instance. Jurisdictions there completed a standard form showing how much money they spent and how it fell under approved uses of the settlement. Sounds great, but in reality, it reads like this. In fiscal year 2023, the city of Chubbuck spent about $39,000 on Section G. Subsection 9, Public Health District Number 6, spent more than $26,000 on Section B, Subsection 2. Cracking that code requires a separate document, and even that provides only broad outlines. G9 refers to school-based or youth-focused programs or strategies that have demonstrated effectiveness in preventing drug misuse. B2 refers to the full continuum of care or treatment and recovery services for OUD and any co-occurring SUD-MH conditions, referring to opioid use disorder and substance disorder or mental health conditions. What does that mean? How exactly are you doing that? Asked Corey Davis, a project director at the Network of Public Health Law, where he first saw the Idaho reports. Does a school-based program involve hiring mental health counselors or holding a one-time assembly? Does treatment and recovery services mean paying for someone's rehab or building a new recovery house? Without details on organizations receiving the money or descriptions of the projects they're enacting, it's impossible to know where the funds are going. It'd be similar to saying 20% of your monthly salary goes to food. But does that mean grocery bills, eating out at restaurants, or hiring a cook? The Idaho Attorney General's office, which oversees the state's opioid settlement reports, did not respond to requests for comment. Although Idaho and other states in this analysis do better than most by having any public reports, Davis said that doesn't mean they get an automatic gold star. I don't think we should grade them on a curve, he said. It's not a high bar to let the public see at some reasonable level of granularity where the money is going. To be sure, many state and local governments are making concerted efforts to be transparent. In fact, 7 of the states in this analysis reported 100% of their expenditures in a way that is easy for public to find and understand. Minnesota's dashboard and downloadable spreadsheet clearly lists projects such as Renville County's use of $100,000 to install a body scanner in our jail to help staff identify and address hidden drugs inside of the inmates. New Jersey's annual reports include details on how counties awarded funds and how they're tracking success. There are also states such as Indiana that didn't originally promise 100% transparency, but are now publishing detailed accounts of their expenditures. However, there are no national requirements for jurisdictions to report money spent on opioid remediation, in states that have not enacted stricter requirements on their own. The public is left in the dark or forced to rely on ad hoc efforts by advocates and journalists to fill the gap. Wading through reports, when jurisdictions don't publicly report their spending or publish reports without meaningful details, the public is robbed of an opportunity to hold elected officials accountable, said Robert Pack, a co-director of East Tennessee State University Addiction Science Center and national expert on addiction issue. He added, people need to see the names of organizations receiving the money and descriptions of their work to ensure projects are not duplicating efforts or replacing existing funding streams to save money. We don't want to burden the whole thing with too much reporting, Pack said, and acknowledging the small governments run on lean budgets and staff, but organizations typically submit a proposal or project description before governments give them money. If the information is all in hand, why wouldn't they share it? Norman Litchfield, a psychiatrist and the director of addiction medicine at St. Luke's Health System in Idaho, said sharing the information could also foster hope. A lot of people simply are just not aware that these funds exist, and that these funds are currently being utilized in ways that are helping, he said. Greater transparency could help get the message out that treatment works and treatment is available. Other states that lack details in some of their expenditure reports said further descriptions are available to the public and can be found in other state documents. In South Carolina, for instance, more information can be found in the meeting minutes of the Opioid Recovery Fund Board, said Board Chair Eric Bedingfield. He also wrote that following KFF Health News Inquiry staff will create an additional report showing more granular information about the board's discretionary subfund awards. A Missouri Department of Mental Health spokesperson Deborah Walker said, further project descriptions are available through the state budget process. Anyone with questions is welcome to email the department, she said. Bottom line, the details are technically publicly available, but finding them could require hours of research and wading through budgetary jargon, not exactly system-friendly to the average person. Click Control F. New Hampshire's efforts to report its expenditures follow a similar pattern. Local governments control 15% of the state's funds and report their expenditures in yearly letters posted online. The rest of the state's settlement funds are controlled by the Department of Health and Human Services, along with an opioid abatement advisory commission and the governor and executive council. Grant recipients from the larger share explain their project and the populations they serve on the state opioids abatement website. But the report lacks a key detail: how much money each organization received. To find those dollar figures, people must search through the Opioid Abatement Advisory Commission's meeting minutes, which date back several years, or search the Governor and Executive Council's meeting agendas for the proposed contracts. Typing in the research term opioid settlement brings up no results, so one must try opioid instead. Surfacing results about opioid settlements as well as federal opioid grants. The only way to tell which results are relevant is by opening the links one by one. Davis from the Network of Public Health Law called the situation an example of technical compliance. He said people in recovery, parents who lost their kids to overdose, and others interested in the money shouldn't have to click through the meetings and then Control F to look for opioids. James Buffetti, New Hampshire's Deputy Attorney General, who helps oversee the opioid settlement funds, agreed that there's probably better ways to share the various documents in one place. That doesn't mean that they aren't publicly available and we're somehow not being transparent, he said. We're certainly being more than transparent. The New Hampshire Department of Health and Human Services said it will be compiling its first comprehensive report on the opioid settlement funds by the end of the year, as laid out in statute. What's the incentive? With opioid settlement funds set to flow for another decade plus, some jurisdictions are still hoping to improve their public reporting. In Michigan, the state is using some of its opioid settlement money to incentivize local governments to report on their shares. Counties were offered $1,000 to complete a survey about their settlement spending this year, said Lena Stebbins, a spokesperson for the Department of Health and Human Services. 64 counties participated, more than double last year when there was no financial incentive. In Maryland, lawmakers took a different approach. They introduced a bill that required each county to post an annual report detailing the use of its settlement funds and imposed specific timelines for the health department to publish decisions of the state's share of funds. But after counties raised concerns about undue administrative burden, the provisions were struck out, said Samuel Rosenberg, a Democrat representing Baltimore who sponsored the House bill. Lawmakers have now asked the health department to devise a new plan by December 1st to make government expenditures public. Toni Torsch, a Maryland resident whose son Dan died of an overdose at age 24, said she'll be watching to ensure the public gets a clear picture of settlement spending. This is money we got because people's lives have been destroyed, she said. I don't want to see the money being misused or fill a budget hole.